hip joint denervation. Sorry. And I'm Sydney Van Wyk. I'm a fellow at the pain clinic here at Montreal General Hospital. So firstly, we'll look briefly at the outcomes. Nothing too surprising here, just the burden of hip pain, the treatment options available, the anatomy and the innervation of the hip joint, and then the outcomes of hip denervation and how to do the procedure. Firstly, briefly, just about the burden of hip pain. About 7 to 10% of people over the age of 45 apparently have hip joint osteoarthritis. A lot of this is not necessarily pain, but studies with imaging. And hip OA prevalence is also gauged at 10% in all comers over the age of 65%, with the lifetime risk slightly higher in females than in males, about 30% in females. These are the three studies I used for the majority of this presentation. You'll see a few other snips from other studies, but for the most part, these three studies. Firstly, an anatomic study by the lead author being Dr. Short. This came out I think about 2.5 years ago. And then there was a review study by the group from Toronto, including Dr. Bhatia, who some of us know. And lastly, a observational study, case report study from Dr. Kapural about cooled RF for hip denervation. So the causes of hip pain, I don't think there's anything too surprising there. Osteoarthritis, probably first and foremost, rheumatoid arthritis, labral tears, osteonecrosis, and so forth. There at the bottom, probably quite important for us, I think, persistent post-surgical hip pain. The management options would include usually just conservative, interventional, and surgical. I divided the interventional between the usual stuff, the intra-articular injections, and then the denervation, which is, I think a lot of us are a little bit less familiar with that than just the intra-articular injection. Conservative measures would include activity, weight loss, physical therapy, the use of assistive devices, and analgesics. Interventional treatments, the conservative component would include, as I said, injections of sorts, local anesthetic, all the way down to regenerative therapies. Surgical management still remains the only option with long-term results, but it does carry a 5 to 50%, 15, that's 5 to 15% failure rate. And the morbidity with the procedure and mortality as well as the cost to the system would mean everyone isn't a good candidate for this procedure. And persistent pain is an issue in 7 to 28% of patients. So I'm going to talk a little bit about the hip innervation, and I'll briefly touch on the posterior innervation. I think there's a lot of variation in the interpretation of some of these findings, but I think one thing that seems to be reasonably clear is posterior innervation is not as important. There are fewer studies, but it does seem to be minimally innervated compared to the anterior capsule. The nerves mostly referred would be branches from the sciatic, the nerve to quadratus femoris, superior and inferior gluteal nerves, but with potential risk of weakness with denervation due to the short course of the terminal or joint sensory branches, as well as the most of these nerves also find their way through muscle. There is certainly a risk of weakness after denervation, and due to the risk versus benefit, it's not really even studied at this stage, I think. The anterior innervation is, as far as we know, where the money is at this stage. It's usually divided into 4 quadrants: the superior and inferior, lateral and medial components. And these are primarily innervated by these three main articular branches, the one from the femoral nerve branches, which are divided into high and low femoral branches. And the distinction is between the origin from the femoral nerve above or below the inguinal ligament. The obturator nerve branches are also classified as high or low, depending on the whether it originates above or inside the obturator canal, or alternatively from the posterior branch of the obturator nerve. And then the accessory obturator nerve also innervates the anterior capsule. So the high branches of the femoral nerve innervate virtually all around the anterior capsule, the lateral and superior parts being more innervated. The low branches are less significant in terms of innervation, but also provides a degree of innervation all around the capsule. If we look at the obturator branches, these are innervate the inferior portions, with the high branches the medial and the low branches the lateral components. And lastly, the accessory obturator nerve, which primarily innervates the medial components of the joint. So this was a study by, as I say, Dr. Short, one of the ones I referenced earlier. It was a very well done study with, I think it sounds like the section was very meticulous. There are 13 specimens where they plotted these, like all of the 13 specimens, articular innervation. And the high femoral branches was found in 12 of the 13 specimens. And they also, so firstly, they looked at how frequently these innervated the joint, and then they tried to find a common space where these can be targeted. The high branches innervated nearly all of these joints, with the low femoral components only innervating 4 out of 13 patients, so a third of them roundabout. And then there was both the high and the low obturator components innervated around 2/3 or so of patients each. The accessory obturator nerve was found to innervate 53% of hips, and although this might not seem too significant, most of the historical studies found this to be more in the range of 20 to 30%, and as a result, I think it seems like most people didn't really bother with accessory obturator nerve, where according to this cohort of 13 cadavers, it might actually be worthwhile to go after the accessory obturator nerve as well. So these are just a few pictures of the femoral articular branches. As you can see on the left two slides, there are the so-called high branches originating above the inguinal ligament, and then the low femoral branches, which were a little bit less significant in terms of the innervation and how commonly they were actually found on dissection. And they didn't really find a very good significant point where these could be targeted either. The obturator articular branches, as you can see here, that would be the area where they exit the obturator canal. And here on the left bottom, again, I hope you guys can see my cursor, but this would be the area where these tend to converge before they enter the joint from an inferior medial direction. The accessory obturator nerve would be the one that's by and large mostly forgotten until now, or most people didn't really bother denervating this component. And as I said, in about 50% of patients, this contributes significantly to the medial capsule. So here you can see on the left-sided picture, it's just a little bit medial of the main femoral nerve. And if you look at the obturator canal, it is a little bit lateral and up above on the ischium, laterally to the obturator nerve and canal. So if we briefly look at previous studies, In 1997, they only denervated 13 patients, obturator nerves only, and in this small group of patients, 12 of the 13 patients had increased range of motion. In 2001, another study was published with 14 femoral branch denervation for lateral pain, and 86% of these patients had a 50% reduction in pain, and this held true for both 1 and 11 months after the procedure. So I'm quickly going to touch on this study by Dr. Kumar, and some of us know Dr. Bhatia in Toronto, about nearly 2 years ago, where they reviewed 16 studies. And as with a lot of new procedures, I suppose there's not a lot of overlap. There's a variety of indications and techniques for the procedures. There's an efficacy that ranges from 30 to 90%, and the duration, as you can see there, between 8 days and 3 years for pain relief. Most of the studies quantified pain relief as 50% reduction or more. They did, however, show a reduction in analgesic requirements. So they looked firstly at this is still the same study. They looked at the use of prognostic blocks, and this was very heterogeneous. Some studies used intra-articular injections, and some used the articular branch blocks for prognostic values. There was a huge variation in the volume of injectate, and their conclusion was that there wasn't enough evidence to determine the value either way. The stimulation prior to ablation, it seems like most people use sensory stimulation to try and elicit paresthesia in the area of the usual pain, with 50 hertz stimulation at between 0.3 and 0.7 volts being used in these studies. Motor stimulation was used less frequently, but that would be mostly for a safety component, I suppose, and the variation there again was significant, with 0.9 to 3 volts being utilized to designate as a safe motor stimulation. The cannula size was mostly a 20 to 22 gauge needle, but again, lots of variation in the tip characteristics, and whether they used curved or straight tips were not specified in the majority of the studies. A lot of variation in the parameters, I suppose, as with most other radiofrequency ablation procedures, between 1 and 3 minute variation in the thermal group, and in PRF also 1 to 3 minutes. There were only 2 case reports in all of these studies about repeat procedures, and again, conclusion was that there wasn't sufficient evidence to say whether this is a good idea or not. Complications were minimal, but there wasn't a very good approach to identifying or reporting these adverse events, and a lot of these patients didn't have very robust follow-up. So their conclusions were that the indications might be the patient risk for surgery, the patient's choice, or if there was a substantial wait time for surgery. They recommended targeting purely the sensory afferent nerves. You may consider prognostic blocks. Lesion parameters should maximize the lesion size. And there should be discussion with patients about the effects of an insensate or a Charcot joint. And they recommended for the obturator to use a medial to lateral approach. So I should have put in medial there, but a medial to lateral approach. And they did mention that the posterior denervation is not well established as a procedure, and certainly the need for more long-term data. So nothing too earth-shattering there. So a few things they found was everyone focused on the anterior denervation. This is still the same study. Some practitioners used fluoro or ultrasound, and some used both. It seems like there was a standardized approach for the femoral nerve, which I will get to in a minute in the procedure. But for the obturator nerve, there's there's a significant variation in the methods used, and the accessory obturator nerve for the most part was not targeted. So if I go back to the first study I quoted, this is the study by Dr. Short again. So they try to find areas that can be found under ultrasound and or fluoroscopy for denervation of potentially up to all three of these nerves. So if we look at the first picture here, number A, that just shows the spine with various placements of the ultrasound probe. B would be sliding from, well, starting at the anterior superior iliac spine, and then to C, we slide down to the AIIS. From there, the probe's rotated about 45 degrees, pointing towards the pubis. In D, and you may recognize this as the appropriate technique for a so-called ping block, which is sometimes done, for instance, for hip fractures or for hip replacement surgery. If we come up to the other side, or I suppose the skeleton's left side, this would be the ultrasound landmarks for the obturator nerve, where E would be the regular view for an intra-articular joint injection, and then the probe is slid down in the same orientation, a little bit caudate and medially, to where you lose the femoral head. You don't see the femoral head anymore, and that would signify the inframedial acetabulum, which is where the high and low branches of the obturator nerve converges. So if we look at the ultrasound image, to be frank, I'm not sure what this ultrasound image is from. I copied it from there, but it should probably be more like the next one, which I'll show you. The fluoroscopy view, as you can see, it's at about the 12 o'clock position on the acetabulum, making sure you stay a good half centimeter or more outside of the capsule. Probably no reason to encroach on that joint itself too much. And some practitioners here would make two lesions here, one about where that needle is situated, and the other one just a centimeter or less cephalad to that. So just going a little bit superior to that. This would be for the accessory obturator nerve, and again, this is on ultrasound, the ping block type view, where you can see the iliopubic eminence here, which is closer to where we would expect the accessory obturator nerve to run. And then a little bit lower down, under the psoas tendon, there would be the femoral nerve branches, most often converging in this area here. And sorry, I'm just going to go back there. So that would be, sorry, I'm just going to minimize you guys. So it would be the middle one of these needles or lines that you can see here would be where we target the accessory obturator nerve. Lastly, the obturator nerve. As I said, these high and low branches tend to converge at the inframedial acetabulum. Again, this is the view, but this wouldn't make sense to anyone if you know it's just slightly medial and caudal to where you would see the hip joint and the head of the femur. It makes a little bit more sense. And the fluoroscopy view would really, the area to target would be just lateral to the incisura, and most practitioners would tend to make a couple of, meaning two, probably two lesions at this site as well. So this study regarding cooled RF neurotomy, they looked at, this was a retrospective study looking at 62 blocks, and they used a combination of fluoroscopy and ultrasound. The fluoroscopy is primarily used for the femoral nerve um, denervation, and for the obturator nerve, they mainly used a medial to lateral approach and used ultrasound to confirm safety and avoid the neurovascular bundle. So they first did 2 diagnostic blocks with a low volume of local anesthetic at each site, and defined a positive diagnostic block as 50% relief in pain. And the obturator, as I said, was done at that incisura acetabula area, which seems to be the standard. I think most people agree on that being the appropriate target point. I think the axis, whether it's from inferior or lateral medial, that is where there's still variation in practice. The femoral branch was targeted at the upper outer quarter of the joint capsule, so at the 2 or 10 o'clock position on just above the hip joint. And they did 1 lesion at each of these sites, and 52 of the 62 patients proceeded to cooled RF because they had 50% reduction of pain or more. They used the Coolleaf 17 gauge needle and injected 1 ml of lidocaine 2% prior to the procedure, and did 3 minutes at 75 degrees, which I believe like correlates to like 90 degrees for regular RF. So the procedure, again, briefly, I mentioned some of this earlier. They used lateral to medial, which seems quite standard at this stage, to bony contact at the 10 or 2 o'clock position just above the hip joint. They were more than 1 centimeter from the neurovascular bundle in all procedures, and they used ultrasound mostly to document that it is safe, not that they necessarily thought it was necessary, but and I think as part of the study, it gives us good information that this would probably be reasonably safe from a lateral to medial approach. They use sensory stimulation, and this was positive for reproducing pain in the usual area of pain in all of these patients, and motor stimulation was negative in all of the patients. The obturator branch, they did a, sorry, someone there? The obturator branch, let me just see. Okay. Obturator branch, they approached from medial to lateral, which frankly seems to be the way things are moving at this stage. They used ultrasound guidance to remain medial to the femoral vein and obviously avoid neurovascular issues. They did state that the neurovascular complex was in close proximity, as you'll see below here. All of these were done safely with the use of ultrasound and fluoroscopy, and they made a second lesion immediately below that first obturator target in the last few of their studies. The sensory stimulation, again, was positive in all of these patients, but motor stimulation was positive in half of these patients, which required needle repositioning of 2 to 5 millimeters laterally. And you can see here, so that would be the appropriate spot for the femoral nerve, let's say on the right side of the picture. This would be, I think this would be a stretch to call this the 10 o'clock position, maybe more 11, but either way, that's what they aimed for, was 10 or 2 o'clock, depending on the side. And then here at the lower margin of the joint at the incisura, the obturator with a second lesion immediately below it, just a few millimeters below that. This goes to show how close they get with the medial to lateral approach. The target being the inferior-medial acetabulum, which is this bony tip here, with the distance only being half a centimeter And this was in a fair amount of patients that they had only between 0.5 and 1 centimeter distance between the vasculature and the needle. Their findings, let me go to the next slide. So their mean pain score prior to procedure was 7.6, and this went down to 2.25 after the procedure. The duration for the first and second procedures were very similar, about a month to better part of a year for first procedure and very similar for second procedures. They had 2 failed procedures out of these 52 procedures. They couldn't find any specific reason for that. One case of neuritis, this was just a burning sensation in the groin for a week. And they found a minimal decrease in opioid use in their group of patients. It was better tolerated than the inferior obturator approach. And I might mention that in a little bit more detail shortly, what I mean by that, in case some of you don't know that. And they did identify a steep learning curve. So they did say the first one, I get the impression most people thought, why are we doing this? And after about 3 or so, most practitioners found this reasonably easy and not too time consuming. They were able to do it in, I think, around half an hour or so for the whole procedure. So I'll quickly touch on this. It is not radio frequency denervation, but this was a study published published a couple of years ago in for use in acute pain management in patients with inoperable hip fractures. So in essence, patients who are poor surgical candidates, not really who wouldn't be candidates for hip replacement surgery. There are 20 patients with hip fractures, and they did all of this with ultrasound guidance. They did diagnostic blocks with reasonably low volume injectates. They used ropivacaine at 2 sites. The first would be for the femoral and accessory obturator kind of complex, and so kind of like a ping block with a relatively low volume. And the second would be for the obturator. If the patients had 50% relief, they would proceed to 100% alcohol for neurolysis, and they used a slightly higher volume of 5 and 3 mils at these 2 sites respectively. And they followed these patients shortly after the procedure and next day and so forth. The outcomes were pain reduction and the increase in hip flexion, as well as the mortality. The results showed a decrease in pain, which I found interesting. So the pain was virtually zero in all patients when inactive, and with flexion, their pain was only reported to be about 3 out of 10. But this did decrease to about 1 out of 10, or on average 1 out of 10 in this group of 20 patients. And they did find significant increase in hip flexion, with a baseline prior to the procedures being at 43% and then going up to about 80% or so on average for the next few days. Briefly on the procedure, as I mentioned earlier, for the femoral nerve articular branches, it was like for femoral and accessory obturator, this is like the ping block type view that you obtain, and then inject. They used 5 mils of 100% alcohol in this area here, which would tend to spread towards the accessory obturator and the femoral nerve down here. For the obturator nerve articular branches, same as the reported study by Short. They would visualize the joint and move caudal and medial in the same orientation, and then target that inframedial acetabulum. So in summary, if you look at the ASRA website, there's a fairly nice, like a one-pager about how to do it, and this author has done a good many of these, and he finds this a safe way of doing it. He uses fluoroscopy and ultrasound, and use one lesion at the femoral branch. As I said, at the kind of somewhere between 10 and 2 o'clock. I think a lot of people get closer to 12 o'clock in the fluoroscopy literature or the fluoroscopy pictures I've seen, but it's stated between 10 and 12 o'clock, or 12 and 2 o'clock on the opposite side. And then 2 lesions at the obturator branch at the incisura. And he also uses medial to lateral. And it really seems to me, if I look at the bulk of the literature, that the medial to lateral approach will probably become standard over time. If you look at the Coolleaf website, they primarily use fluoroscopy, and they say you can use ultrasound with it or not, your choice. But they use an inferior approach for the obturator branch, and this is a very long needle tract starting in the medial groin. I think it's probably quite safe. You're reasonably parallel to the femoral vasculature, and there's a degree of safety in there. But when you look at the other studies promoting ideas like, let's say, that ASRA approach, or the one from Dr. Bhatia that I'll mention in a minute, they do say that they find it's much more, the other options are better tolerated. That inferior approach is a very long tract and not well tolerated by patients. I spoke to Dr. Bhatia in Toronto. They do a fair amount of these procedures, and they use a combination of fluoroscopy and ultrasound again. Very similar to the ASRA approach, except they primarily focus on the, so if they do when they do the femoral approach, they do it like a ping block with checking with fluoroscopy, but also using ultrasound and finding that ping block type of landmark. Then they would do 2 to 3 RF lesions there, and I think the idea is that they would also try to incorporate the accessory obturator nerve in this area of lesion. The obturator would be anteromedial. They would only add for anteromedial pain. So like the one study I mentioned earlier from 2001, I believe, where they don't necessarily do all nerves in all patients. If the patient has a significant amount of anteromedial pain, they would add the obturator component, which they frequently do, and then do 2 or 3 lesions at this obturator site. Very similar to the one that I described by ASRA and from previous fluoro and ultrasound views I showed. The chemical neurolysis, the approach is similar to the one by Dr. Bhatia, as I showed in the previous pictures. So the considerations in my mind is with radiofrequency denervation, is there a need for accessory obturator nerve RF ablation? The older studies seem to not really care too much about the accessory obturator nerve, but it seems to innervate a substantial part of the medial capsule, and more commonly than previously thought. There is a steep learning curve for the radiofrequency denervation procedure, and the safety of the obturator approach might guide how you do these. I think the femoral part is the easy part from what I've read and seen. The obturator approach would be at least initially technically a little bit difficult doing medial to lateral, but potentially the safest or safer way. Inferior approach might also be fine, but at the expense of patient comfort. With chemical neurolysis, it's probably potentially easier. It's more like a nerve block, a little bit easier, smaller gauge needle. The duration is very unsure. In this study, they only followed up to about 4 months. And if I look at extrapolate other studies, there's quotes from 2 to 9 months for average chemical neurolysis efficacy. But this is not primarily this is not for hip denervation. This is looking at neurolysis done chemically. The efficacy in chronic hip pain versus acute fractures, I'm not sure we can with certainty extrapolate that someone with an acute hip fracture that responds to this chemical neurolysis would respond to, or patients would respond when they have chronic hip pain as well. We're not always sure even what the pathology and the cause is, so it may not be prudent to extrapolate that. And the optimal volume is not certain at all. I don't even think there's been enough data for fluoroscopy injections to see how commonly these would spread, how far. But there is a question whether RF ablation or chemical neurolysis is would be the best in the long term. I think the chemical neurolysis seems quite easy, but the RF ablation may certainly trend towards longer lasting results, albeit a little bit technically a little bit more difficult, and certainly likely to last a bit longer. And that was it.